By the time I met this patient, we weren't his second or third or fourth opinion. That number had gotten much higher. This by itself would be fine, but the issue was that he had an aggressive lymphoma. It could be cured, but it needed to be treated right away.
When I give talks about meta-analysis, I usually start off with a multiple choice question.
I'm going to go with E, all of the above.
You win.
I knew it. I know your wry sense of humor.
Let me give a little bit of background.
This is Blood and Cancer, the official podcast of MD Edge Hematology Oncology. I'm the voice of MD Edge Podcasts, Nick Andrews. Welcome to episode 34. I'm joined this week, as I am every week, by our editor-in-chief at MD Edge Hematology Oncology, Dr. David Henry, who was in town at our DC office today, but I believe he's made the trip back up north to Philadelphia.
I made it back home. The wonders of the East Coast and the Acela, it's a great, who would drive? It's just so nice on the train. So I'm down and back in Philadelphia, just having gone through a nice evening, early post-Labor Day storm.
Yes, I love that commuter train. It is weirdly romantic, and if you are so inclined, it's not that difficult to get some quality work done. It really isn't.
All true. Yeah, it really is a pleasure.
Okay, so this week we have somebody that is one of our favorite guests and breaking down something that we think we all should know each and every time he's on, and that has to do with data and how studies are presented and what one can get out of studies. This week the topic is meta-analyses, and our guest is, of course, Dr. Streiner.
Well, he does a great job with this. He really dumbs it down for us in clinical practice who wish we knew this statistical field as well as those who do. And this week we tackled meta-analysis. So the idea is, I'm sure most listeners know, is you have one study or a second study or a third study that may say something about an outcome you'd like to know what to do, a new drug, a new device. And before meta-analysis, which he reports occurred in 1977 is when this technique was invented, you'd have some thought leader review and give his opinion. Well, now you can put these studies together. However, of course, the bigger, the greater the power of the study analysis and the outcome to say more conclusively that yes, this particular A versus B, B is better, A is better, no difference, given all the power of the number of studies.
Which I think is very important because, I mean, even when you have a very well put together randomized placebo-controlled phase 3 trial in the best circumstances, there can be, weirdness. And as a result of that, these meta-analyses have a way of cutting through that and say, this is the scope of everything that we know. And it all depends. I mean, I'm assuming, and you can hear later in the interview, it depends a lot on the selection of the different studies and what the co-founders were in those particular studies. And it's one of those things where you can get bogged down in the details, but the meta-analysis is one of my favorite kind of studies to read.
And he really goes through that, just as you suggest, not all studies are created equal. So he said the technique weights them. So you have a well-done study with 200 patients and a sort of well-done study with 20 patients. Their technique reviews that and weights them and puts that weighted effect into this total analysis.
And interpreting the data is one of those skills where you really just want to stay updated so that when you see the numbers, when you see the phrases, you understand what you're looking at. So we're looking forward to that. That's coming up. As always, following our interview portion of the show, Dr. Ilana Yurkiewicz, Hematology Oncology Fellow at Stanford University, will be joining us for clinical correlation. The topic this week is another good one, and that is when a patient seeks a second opinion. Man, it's such a difficult thing being diagnosed with cancer, and can't blame people for seeking a second opinion. So it's going to be a really interesting topic again.
Another wonderful topic choice by her. It's a great idea, and I think anybody should be thinking about a second opinion when something so significant and serious is being talked about and diagnosed with them, and maybe I should hear from somebody else. And so seeing a patient for the first time, as I conclude, I go, you may hear from Uncle Fred or Aunt Sally that they have a friend in this particular center and they should see you. And I say, that's great. In fact, I'll help you do it. But I think, as Ilana points out, you can go second, third, fourth, fifth opinion. Meanwhile, your cancer's doing something, and there comes a point where you should get these done quickly or help the first guy get you to the second guy. And so she talks all about how to get the second opinion. Don't wait too long. Get help. Bring it up.
Such important advice for not only for patients, obviously, but for the care team. It seems like whenever the diagnosis happens, the clock starts ticking immediately, and I can't imagine what that must feel like. It must be like a tip-off of a big game.
So it's a good analogy. Yeah, the patients do feel, and the families do feel that clock ticking, and this piece will help people understand. Sometimes it takes too long, and we need to help our patients get through the second opinion process.
So that's Dr. Ilana Yurkiewicz. She is Hematology Oncology Fellow at Stanford University. Clinical correlation always follows our interview portion of the show. Is a nice way to put a bow on the episode and remind all of us that data this, guidelines that. It's all about treating people and treating patients. So it's a great way to end each and every episode.
Indeed, yeah.
Let's take a look at this week in Hematology Oncology from MD Edge Hematology Oncology. Dr. Henry, it is ESC 2019, the European Society of Cardiology. And I read this headline and I thought, what the hell is going on? So let's go ahead and read this. This is the first paragraph of our story by Kari Oakes, one of our favorite reporters. Bleeding after acute coronary syndrome is associated with an increased risk for a new diagnosis of cancer. This is new data coming out of ESC 2019. Of 3,600 patients who were discharged with dual antiplatelet therapy after acute coronary syndrome, 1,200 had post-discharge bleeding. Taken together with that, patients who bled had a hazard ratio of 3.4 for a new diagnosis of cancer. That gives you a lot to think about.
Well, this side had to double take when I saw this headline and a little bit of information. So the patients had an acute coronary syndrome. Something's been done. Almost always these patients are put on dual platelet therapy. An aspirin drug like aspirin and a platelet inhibitor like clopidogrel are common. And then patients, of course, can bleed. You're affecting their platelets. But in this analysis, if in this setup of acute coronary syndrome and dual platelet therapy to keep your grafts or your stents open, you bleed, you have this pop in your hazard risk of getting a cancer, any cancer. So this should make for some very interesting reading to see if this data holds up.
Right. The presenter of the data said, and this is a quote from the story, a plausible reason for this link is that there is a pre-existing subclinical lesion in an organ that is triggered to become cancer by antiplatelet drugs or some sort of stressful situation such as a heart attack. But it was really, it's one of those headlines that grabs you, you read the story, but the hazard ratios were so much bigger than one. It was just really, really fascinating. So I think if you were a researcher in this area, you must be really chomping at the bit to be like, what is going on?
Yeah, this will make me look twice when I see a patient who's had such a syndrome and dual platelet therapy and wonder what I should be watching for.
Well, speaking of doing double takes when you see data, it's time to kick it over to the interview with Dr. David Streiner, who is going to teach us or remind us or refresh us about what is going on with meta-analyses.
Here he comes. He's well worth listening. Enjoy it.
All right, Dr. Henry, welcome back to Philly. We'll see you next time.
Thanks, Nick. Talk to you soon. Welcome to this podcast. You're listening to the podcast entitled Blood and Cancer. I'm Dr. David Henry, host of this podcast and also editor-in-chief of the online journal mdedge.com/hematology-oncology. Quite a mouthful, mdedge.com/hematology-oncology, where you can see this podcast show notes and previous archived podcasts of Blood and Cancer, along with the show notes of each one. And I'm delighted today to have, yet again, our guru statistician, Dr. David Streiner in Toronto, Canada. David, are you there?
I'm here, but not in Toronto. I'm in Hamilton.
Oh, I beg your pardon. And are you still at the University of Toronto, or has that changed?
Well, my main appointment is McMaster University here in Hamilton, but I also teach at the University of Toronto, so it's both affiliations.
Well, as I like to tell our audience, you are a PhD in psychiatry.
No, psychology.
I beg your psychology, yeah. And somehow a genius in statistics. And a few years back, and our audience can refer to in print, you and Jeffrey Norman, similarly genius in the statistics and statistics of medicine, did a book and also did a series with us in our previous edition called Community Oncology, and we'll have that reference, especially to today's topic, on our website, which I just mentioned. So without further ado, let's talk about this really tricky, interesting thing called meta-analysis. And from a layman's point of view, as a practicing physician, because we all wish we knew statistics like you, it says to me there's a couple of publications, studies of a particular problem, as you point out, the question, and some are a little bit stronger than others, and maybe the one or two negative. And so wouldn't it be nice if we could lump those all together? And so the meta-analysis actually does that. So maybe if you could explain how it does that, and then I'll pose a couple questions to you. So what is this meta-analysis thing?
Okay. When I give talks about meta-analysis, I usually start off with a multiple choice question. Meta-analysis is a rigorous method for objectively combining the results of many different studies to arrive at a better estimate of the truth. B, the greatest boon to humanity since the invention of the double bed. C, a way of combining the results of many inadequate studies to arrive at an inadequate answer. D, a new growth industry allowing people to build up their CVs. And E, all of the above.
I'm going to go with E, all of the above.
You win.
I knew it. I know your wry sense of humor.
Let me give a little bit of background.
Sure.
Maybe that will help. Before meta-analysis, if somebody wanted to summarize the state of the art in an article or one of the annual reviews, he or she would publish an article saying, I've read a lot of articles, and this is my take on where the field is now. Problem is manifold. First, we don't know how thorough that person's search of the literature was. Did the person look for all of the available articles or just the ones that he or she happened to stumble on? Secondly, we don't know how much the person's biases for or against the intervention may have tempered the interpretation of the articles. Be very, very critical of articles that were opposed to his viewpoint, be very supportive of articles that supported his viewpoint. So the next stage was to try to systematically gather all of the available studies and then put them into two piles. One, supporting the effectiveness of the intervention, and the other pile, refuting the effectiveness of the intervention. And then just simply count up how many articles were in each pile. This vote counting was an improvement, but it wasn't good enough because all studies were given equal weight. So a very small study with few participants, poorly analyzed, got as much weight as a very large study that did the intervention very well. So Smith and Glass, in the middle of the 1970s, introduced a technique called meta-analysis, where what they did was for each study extract what's called an effect size, some estimate of how big the effect was, and then mathematically combine all of these effect sizes to come up with an overall answer, whether the intervention was effective or not. And since that time, meta-analysis has become a bit more sophisticated, with people doing evaluations of the individual studies, so that studies that were better designed, studies that were larger, got more weight than smaller, more poorly designed studies. And that's the essence of meta-analysis, a systematic, thorough review of the literature, extraction of the effect sizes, and then mathematically combining the effect sizes to get one overall estimate.
So if I could just say what I'm hearing and what it means to me is the studies as they're combined, the method takes the quality, somehow assigns a value of the quality of the individual studies, and then a study of 20 people is weighted differently from a study of 2,000 people.
Right, exactly.
Well, this is, of course, a great help. I'm surprised it took until 1977 to think of this, because you're right, up until then, someone would review the literature and give an opinion based on a mental evaluation, probably not always too far off from what the real meta-analysis would show, but some were maybe off, of what we should do with a particular clinical issue and therapy or diagnosis or understanding of literature. Did negative trials, so negative trials get in this as well as positive trials?
Oh, absolutely. Absolutely. And in fact, that's one of the advantages of meta-analysis, and good meta-analyses try to dig out negative trials, because there are two biases against negative trials. They're less likely to be submitted to a journal than positive trials. And if they are submitted, they're less likely to be published. So what appears in the literature may be a biased reflection of the true state of affairs.
Well, let's then go to a specific example, which we are going to discuss. And this will be in our website in the show notes. The article is from the British Journal of Cancer in 2010 from both John Glaspie. And the title is Erythropoiesis-stimulating Agents, the so-called ESAs, in Oncology, a study-level meta-analysis of survival and other safety outcomes. And as many of our gray-haired listeners may recall, this goes back to the 80s and 90s, when the ESAs came into oncology, and treating anemia was a great idea, and patients would feel better by some quality of life studies. And so we kind of got out of control back in the 90s, and we thought more was better, and we drove hemoglobins higher. And all of a sudden, some negative safety signals appeared. The first one was from the so-called BEST trial, unfortunately, in breast cancer patients. The study came out of the UK, and then we started to find others like it. So there were many positive in survival and tumor progression, and there were many negative, or some negative. And there was the FDA got wind of this and convened a meeting to go over what really was going on, which spoke to the issue. But then this article, which I'm referring to, had 60 trials of whether or not, in meta-analysis combination form, of whether or not there was a safety signal or not. So maybe if you could talk us through that article, what did Dr. Glaspie and colleagues do, and what did you think of their meta-analysis?
As you said, they gathered what I assume are all of the articles that investigated ESA, and they also looked at unpublished articles or unpublished works,
right,
from poster presentations, for example, that may not have made it into press. And there's controversy about this. On the one hand, as we discussed just a few minutes ago, it's important to include negative trials because they could also show what's actually going on. On the other hand, the feeling is if it's a good study, even a negative trial, it should have been published. And if it was just a poster presentation, a paper read at a conference, it didn't go through the same peer review process as a published paper.
Right.
So there's some controversy whether or not to include unpublished papers. My own bias is to include them, but then to do a sensitivity analysis to see whether the results differ depending on whether you include or don't include the unpublished studies.
Mm-hmm. And this publication we're discussing, so this article, meta-analysis of some 60 trials, had published and unpublished data in it.
Yes.
Mm-hmm. Yes. And I'm looking at it, and again, our listeners can see this online. There's this thing called the forest plot. I see a lot of horizontal lines, some very long, some very short, right around this center line of 1. Can you decode that for us? What's this plot?
That center line of 1 reflects a relative risk or an odds ratio of 1, which means no difference between the groups. That's the null hypothesis. And each of the lines has a point somewhere in the middle of it. And that point represents what's called the point estimate of the study. Those where the squares are to the right of the line favor the control group. Those where the squares are to the left of the line favor the ESA group. The width of the line, as we discussed in a couple of previous podcasts, is the confidence interval. So that very large studies should have very small lines on either side of them.
So you're more certain of that result.
That's right. So the Smith article, if I'm reading the forest plot right, let's see, 1, 2, 3, 4 down, 1, 2, 3. Yes, Smith 2008. You'll see it has a larger square, and usually the size of the square represents the sample size. And because the sample size is larger, the confidence intervals are smaller, meaning we are more confident about the accuracy of their estimate. The first article has very, very broad confidence intervals, so they could be anywhere, all over the map. And then if you look down to the bottom of the AOC group of studies, you see a diamond shape, and that's the summary. That's the effect of combining all of the previous studies and getting the meta-analytic estimate of the effect size.
So that's the meta-analysis result in this thing called the forest plot, which shows it, the width of the line, large being not too confident, tighter, smaller being confident, and then that diamond at the bottom. In this particular trial, it touches 1. So what's that mean, the diamond?
That means that the results are inconclusive. There's no significant relationship one way or the other. There's, in essence, no difference between ESA and no ESA.
And this was an outcome variable of survival, so it didn't favor ESA for survival or favor ESA for hurting survival.
Right, exactly.
Okay. Yeah. All right, and did you feel that the quality of the study was 60 trials and over 15,000 patients, that it was a well-done analysis from what you saw?
Yes, it looked like a very well-done analysis. They did the right things in terms of how they analyzed the data, or what's called a random effects model. The only thing that I didn't see, which may mean that they didn't do it or just didn't mention it, is that it's customary to weight each article, as I mentioned, by the sample size.
Mm-hmm.
Or
the quality.
The inverse of the variance, so that the studies that had a smaller variability got more weight. And I don't recall reading that the studies were weighted by the inverse of the variance.
Okay. I enjoyed, again, what you've written on this, and I'm going to take a quote out of your final paragraph, which were 2 most interesting quotes. One was, while we've been discussing this and we've gone through the basics of it, there are at least 12 separate steps you and Jeff report in the meta-analysis, and your bottom line says the bottom line is to regard each meta-analysis as an estimate of truth, not truth itself.
Absolutely.
Yeah. So then in summary, this really interesting technique of the meta-analysis took us from review and opinion and thought leaders to a more objectified, statistically increasingly improved model of taking studies, pro and con, published, unpublished, evaluate them, weight them, put them in this analysis, show the data on a forest plot, and get that little diamond at the bottom, which touches or doesn't touch 1 to tell you the estimate of truth either does or doesn't say one thing one way or the other about the question at hand.
Exactly. Yeah. Overall, it was a very well done study, beautifully summarizes the state of the literature.
Well, very good. I think we've covered that beautifully, and I'm going to tease our audience going forward. You mentioned some other interesting analyses which this leads to. One I call the multiple regression. I have difficulty getting my head around one regression, let alone multiple. So I can't wait for that interview, which we'll do a few weeks hence, and tease our audience to listen, because you've been listening to our podcast, Blood and Cancer, which you can get and subscribe to on iTunes or wherever you get your podcast material. It mails, so to speak, comes out online every Thursday morning of each week, and you will see it referenced on our webpage at mdh.com/hematology-oncology, where show notes will be done by several of our wonderful residents at Pennsylvania Hospital each week. So I want to thank you, David, for once again helping decode this mystic field of statistics.
It's been a pleasure talking to you.
Thank you so much, and thank you all for listening.
And that concludes the interview portion of our show this week. Remember, there are robust show notes available wherever notes are found in your podcast app. Coming up next, Clinical Correlation with Dr. Ilana Yurkiewicz. Welcome back to Blood and Cancer, the official podcast of MD Edge Hematology Oncology. I'm the voice of MD Edge, Nick Andrews. It's time now for Clinical Correlation with Dr. Ilana Yurkiewicz.
I'm Ilana Yurkiewicz, and this is Clinical Correlation, a segment about the human side of hematology and oncology care. This is a story about second opinions. Working in an academic medical center, I meet a lot of patients who are coming for second opinions. Sometimes they are interested in clinical trials, sometimes they are still doctor shopping, and other times they simply want to hear another physician's take on their situation. It's all valued and recommended. Patients are in charge of their own fate and bodies, and it's perfectly reasonable and encouraged to seek second opinions. This is a unique story of where that can go wrong. By the time I met this patient, we weren't his second or third or fourth opinion. That number had gotten much higher. This by itself would be fine, but the issue was that he had an aggressive lymphoma. It could be cured, but it needed to be treated right away. I could see the appeal from his point of view in seeking so many opinions. This was his life, and he wanted all the possible choices before making the most important decision of it. Moreover, by committing to one clinical trial, for instance, he would actually necessarily be excluded from another. The options seemed endless, and he was understandably incredibly stressed by the pressure of the decision. But by delaying making any decision, by being so thorough and meticulous, this actually was causing him harm. There's the saying, done is better than perfect, one I often repeat to myself when I need to make deadlines, but I also thought of it when I met him. This was a situation where it really applied. Make a decision and get the treatment done, or he could lose his window for cure. The attending I was with got to the heart of it by saying this directly. He was emotionally insightful and upfront, and it made a difference. "Can I give you some advice?" he said. "Don't seek any more opinions." Later that day, the patient called back and agreed to be part of a clinical trial we were offering at our hospital. Within days, he got treated. It's too early to say, but I'm optimistic for cure. Thanks for listening, and I hope you'll tune in next week for Clinical Correlation.
A big thank you there to Dr. Ilana Yurkiewicz. A reminder, Dr. Yurkiewicz writes a column or a blog entitled Hard Questions. It's available at mdh.com/hematology-oncology. And that does it for this week's edition of Blood and Cancer. Blood and Cancer is hosted by MD-Edge Hematology Oncology Editor-in-Chief, Dr. David Henry. Our guest this week was Dr. David Streiner. Clinical Correlation is written, produced, and recorded by Dr. Ilana Yurkiewicz. Show notes are authored by Dr. Emily Bryer. Blood and Cancer producer is Mary Ellen Schneider. All of MD Edge podcasts are produced by our editor-in-chief, Mary Jo Dales. Executive editors Denise Fulton and Kathy Scarbeck. and multimedia editor Terry Rudd. Our social media is produced by Kyla Clark. I am your audio editor, audio engineer, and the voice of MD Edge Podcasts, Nick Andrews. We thank you for joining us for episode 34 of Blood and Cancer, the official podcast of MD Edge, Hematology Oncology.